Hello, I am Professor Dylan Ritchie, and this is Nursing 310A Fundamentals of Nursing 1, Module 7 here at Aspen University. And today we're going to discuss bowel elimination in nursing. So let's start off with the open-ended question that most of us will face as frontline nurses, and that is, what is normal bowel elimination? This can be described from person to person differently. Truthfully, the answer is very open-ended, and it is whatever the person says is their normal elimination pattern that they've experienced from life thus far. Common problems that we'll know across our various patient populations, no matter whether you're working on a med surg or an oncology unit, these type of bowel related problems are naturally something that you're going to experience. Constipation. Constipation is defined as fewer than 3 bowel movements a week. This typically actually occurs in medicine more frequently in women and then men, and as the patient population approaches 65 and older, we have increased incidence. Causes can include, but are not limited to, medication regimen, ignoring the urge to defect and having more or less rejection of a natural bowel pattern, diets that are low in dietary fiber, paired with another common one is low fluid intake, especially chronic low fluid intake. Spinal cord injuries and trauma can account for this as well. Patients may have other bowel related issues with constipation secondary to hemorrhoids. Diarrhea is the opposite. So diarrhea is also an abnormal bowel frequency paired with typically more fluid based bowel movements. This can be secondary to allergies or intolerance to foods. Antibiotic use is notorious for causing GI issues, including diarrhea. Misuse or overuse of laxatives, foodborne pathogens. Thinking a little bit bigger and heavier, you can talk things, maybe you have either acute or chronic colon diseases. Patients that are on regular enteral nutrition, it's a liquid-based nutrition from the get-go, they also have significantly liquidier stools. Another issue in this arena that you'll note, it will be incontinence. Incontinence is the involuntary control or total loss of fecal discharge through the anus, and it's a risk, big risk with fecal incontinence is risk for skin breakdown. And another kind of a stigma once patients have this for a chronic window, there's also some social isolation that can come from this regularly because they simply either don't want to go out or their fear of some type of stigma or judgment from others. Moving on and talking about impaction. Impaction is the presence of a hard fecal mass in either the rectum or colon that the patient is simply incapable of expelling. These are commonly seen in debilitated, unconscious, or severely confused patient. The cardinal sign, usually that patients will describe or a nurse will describe, is that the patient continues to ooze, essentially a liquid stool or smear, with no normal stool or amount of stool following. That's typically a telltale sign that might cue you in to think we might need to get the patient to someone, at least to be assessed by a GI specialist. Diversions. So we both have the colostomy and the ileostomy. So let's compare those two. The colostomy can be temporary or permanent. The colostomy site is dependent on the disease process. And if you go to page 1009 in your book, it has a really good illustration of the various options for colostomy sites. And it most commonly gives access into the descending and sigmoid colon are the most common places. Now, the ileostomy is created in the small intestine. It also can be temporary or permanent. You have minimal odor, and stools are more frequent and more liquidy with an ileostomy. And the pouch is now more common Surgical procedure. The ileoanal pouch is a now more common surgical procedure. So let's talk about factors affecting bowel elimination. So the first, and probably the one that weighs in heavily, most heavy, is personal factors. So privacy is important to most people, as is sufficient time to have a bowel movement without feeling the need to hurry or rush. Clients working in fast-paced jobs may have difficulty even consciously recognizing that they need to go to the bathroom. Some habitually ignore the need, all of which over a long period of time can promote to bowel dysfunction, especially when we start stacking these different factors on top of each other. Socio-cultural factors include stress. Stress has a major influence on motility of the GI tract. It causes diarrhea and constipation. Stress impacts others differently, but nonetheless, there is a common theme of GI impact. Stress is a primary risk factor in the development of irritable bowel syndrome, which is a disease associated with bloating, pain, and altered bowel function. So let's switch gears and talk about nutritional and hydration factors. So foods and fibers are two very large impacts on the GI tract. Regular intake of food promotes peristalsis, or the movement of that GI tract. People who eat on a regular schedule are likely to develop regular pattern of defecation. On the flip, irregular eating creates irregular bowel elimination. We just said food intake regularly stimulates the GI tract to keep things moving. So if you're not eating regularly, naturally your GI tract is sleeping and waking up, if you want to use that analysis, much more irregularly than that of Joe Schmo, who's out there eating food regularly. Adequate intake of high fiber promotes peristalsis and defecation by increasing the amount of bulk in the GI tract. Bulk foods absorb liquids and increase the mass, or the stool mass. That increased mass actually stretches and forms within the bowel walls, initiating peristalsis again and the defecation reflex. So let's talk about the fluid impact. Fluid is very key in the amount that you're taking in. It is recommended that a minimum of 6 to 8 ounces, 6 to 8 ounce glasses of water, which really kind of cues into more closer to 1,500 to 2,000 mLs of water per day, is what is recommended to promote healthy bowel function. Inadequate fluid intake or excessive fluid loss, as in diarrhea, vomiting, acute illnesses like the flu, it actually slows down peristalsis and leads to dry, hard stools that are significantly harder to pass. Activity. Physical activity is needed. It is required to stimulate peristalsis and bowel elimination. Sedentary people are likely to have weaker abdominal muscles. So they're sitting and not using that muscle mass, that obviously goes away. The core muscles play a large key in what's going on directly behind that muscle wall in the GI tract. Clients with health concerns that have limited activity, think chronic shortness of breath, chronic pain, or medically required bed rest, often experience increased incidence of constipation. Now, medications compounding on all of the two that we just talked about, previous bullet points, really can cause some issues. All oral medicines have the potential to affect the function of the GI tract. You would have to consult with your provider team paired with all of the disease processes to really assess how at risk your patient is based on their medication regimen paired with their lifestyle and other disease processes. Surgery and procedures is the last one I would like to highlight. Manipulation of the bowel often is required and occurs during surgery. The surgical team will physically move so that they can access whatever organ system they're trying to attempt surgical intervention on. That requires the bowel to actually reset and go back into place, which it is capable of doing, but nonetheless, that during that window of time the bowel is resetting and waking up has a large impact on bowel elimination shortly post-op. Abdominal or pelvic surgery in which the bowel is manipulated, it also may create a perilytic ileus, which is the cessation of bowel peristalsis completely. Although peristalsis halts, the bowel continues to produce secretions. Without that peristalsis, secretions remain stagnant and it can cause significant distension and discomfort. To decrease the complications of a perilytic ileus, patients who have GI surgery or bowel surgery typically have a nasogastric or NG tube with low, constant, or intermittent suction occurring. The NG tube is removed after secretions have been removed and peristalsis returns. So, question for the group. And there's no right answer or wrong answer, but when nurses are assessing patients, we often kind of take for granted how uncomfortable that conversation may be. So, cueing into that thought a little bit more, how comfortable would you be discussing your bowel elimination with an elderly patient or teenage patient or a family member, and kind of flipping the script? It can be uncomfortable. So just kind of keep that question in mind. And leading with that, we'll roll into nursing assessment with that in the back of our mind. This can be uncomfortable, and we might have to try to really get creative and create a zone of comfort when we're trying to get our patients to share some of that subjective information about what is naturally an uncomfortable topic for most, talking about bowel elimination and bowel patterns. So jumping right into nursing assessment, we are going to obtain a focused nursing history. Because bowel patterns vary, you will need a nursing history to determine what is normal for each client. Going from patient room to patient room will be a significantly different story when we're talking about elimination patterns. As you interview your clients, pay attention to their reactions to your question. Many people are embarrassed about discussing bowel function. Tailor your assessment to the client's needs and use language that makes the client feel comfortable. Next, we can talk about the focused physical assessment. So the physical assessment for bowel elimination includes an examination of the abdomen. If needed, based on disease, there may be an assessment of the rectum and or anus area, as well as describing characteristics of normal and abnormal stools for that client. You may, depending on if a sample is being collected, observe size, shape, and contour of stool, as well as compare the things that are going on with the contour of the abdomen. You may need to focus in and listen to bowel sounds. You might also palpate the stomach and abdomen dependent on what the patient reports. So now diagnostics, as we escalate this, may be utilized so that we can actually see what's occurring in that GI tract. So indirect visualization studies are radiographic views of the lower GI tract. The simplest of the tests is the abdominal flat plate. It's an anterior to posterior X-ray view of the abdomen used to detect things such as gallstones, fecal impaction can be picked up, and distended bowel. Direct visualization is used for diagnostic and treatment purposes. These are invasive procedures and are conducted by a gastroenterologist who inserts various instruments such as an endoscope to examine the interior of the GI tract. The nurse's role during these studies is to prepare the patient for the test, function as a medical assistant, and provide after care. Another intervention that you might see is the EGD when they're going through the mouth to look at the stomach. That is the esophagogastroduodenoscopy, EGD. Colonoscopy involves the use of a scope inserted through the rectum to visualize the colon. You may have to order or observe stool for occult blood. You can perform the test for occult blood at the bedside although some institutions require that it be done in the laboratory setting. So follow your facility's policy here. Uh, it requires the use of a special reagent that detects the presence of perioxidase. Perioxidase is an enzyme present in hemoglobin. It only requires a small smear of stool, so not a large stool mass is required for this test. And actually, it can be taught to be occurred at home. For home testing, you want to remind patients to wash their hands before and after collecting the specimen. Foods like beets, broccoli, cantaloupe, carrots, cauliflower, cucumbers, grapefruit, radishes, red meat, turnips, and vitamin C enriched food and drink may have impacts. We might use stool testing actually to check for ova and parasites. In assessing a child, you can spread the buttocks while the child is sleeping and examine the anus to see whether any pinworms are visible to the naked eye. You can test for the presence of eggs with tape. In the morning, as soon as the patient awakens, you can press clear cellophane tape against the opening to see if any ova or parasites can be collected in the home. And when you remove the tape immediately, place the adhesive side down on a slide. This will help examine if there's any potential eggs. You may also be required to do a perianal swab for microscopic study. You may also check at night by using like a quick light or flashlight, and the test may have to be repeated on consecutive days. Ova and parasites are tricky in that we actually need to capture presence of either the specimen itself or eggs that they are laying for further reproduction. So another question, what teaching would a patient need in order to obtain a fecal sample? These are things that you as a nurse will have to provide education for at the front line for your clientele. So you would educate the patient on the procedure to get the specimen itself. You may talk about the requirement for either a clean commode or a specipan in the commode, or utilizing any other laboratory equipment or specimens provided by the facility. You are going to talk about and educate how to properly put the specimen in the container provided, and you're going to potentially, if a lab specimen cannot be directly taken to the lab, you will require refrigeration. So what about a fecal occult blood test? What would cause a fecal occult blood test to be inaccurate? Well, like we said, certain foods and supplements, eating red or rare meat, raw foods such as fruits and vegetables, think horseradish, turnips, cantaloupe, broccoli, cauliflower, uh, and beets, to name a few, that can impact the accuracy of the fecal occult blood test. So let's talk about our nursing diagnosis and maybe, get a better understanding of what we'll see as we make those nursing plans of care. Bowel incontinence. Bowel incontinence is a change in normal bowel habits characterized by involuntary passage of stool. Diarrhea is the passage of loose, unformed, or watery stools, or on the flip, constipation is a decrease in the frequency of bowel movements resulting in passage of hard, dry stools. Both can be broken down into temporary or chronic. In the example of constipation, temporary constipation will be lasting short times, and nearly everyone will experience constipation one time or another. Or, comparatively speaking, chronic constipation typically lasts 3 months or longer and can persist up to many years. So what are the outcomes that we want to see? Simply put, our outcome that we're striving for the patient is control of defecation, and when they are defecating, we want to have soft, formed, regular stools. So how do we get there, and what are things that nursing interventions we can provide for regular defecation? Privacy and working with our patients is key here. Again, we talked about it earlier. Patients, simply put, are most common than not embarrassed by either talking about and especially being observed going to the bathroom. So work with your patients, come up with a plan that makes sense for both parties going on, dependent upon fall risk and ambulation. Now, other things the nurse can do include positioning. We want to get the patient in a comfortable position, seated upright and safely on the commode, bedpan, or bedside commode. We can talk about timing, and we can make a bowel regimen with our patients. Again, this is very subjective, and it really depends on what your patient has going on, paired with how they can assist. Often occurring after meal times. Some clients may need assistance. You might have to be a little bit more hands-on with timing and getting them to and from the commode. As a nurse, we can encourage and educate on fluid intake. We want to have our patients drink 6 to 8 glasses of fluid daily. And we can share, fun fact, that hot liquids and fruit juices often increase peristalsis. The last two that we want to talk about are diet and exercise. These topics of conversation you'll never get away with from nurses, whether it's GI or any other disease process. But in the lens of GI specifically, we can provide education on the importance of high fiber intakes via fresh fruits, beans, vegetables, bran cereals, and we can encourage any and every whole grain. On exercise front, we really want to get our patients moving regularly. We want them to strive for 3 to 5 times a week of exercise. We can do range of motions for clients who are on bed rest and help encourage some of that peristalsis. We want at a minimum patients walking 10 to 15 minutes at least, and that has been shown to increase digestive functioning, especially when walking after meals. That's really a great time to get even a short walk in. And there's a lot of studies to show how that impacts bowel regimen. So what about nursing interventions for diarrhea? We can monitor the stools and assess frequency, amount, color, and consistency of stools, especially as that episode continues on, to determine the severity of that bout of diarrhea. We can assess and monitor for potential fluid imbalance. We want to monitor our patient's I's and O's, body weight, and vital signs to address and assess hydration status. Other things that we sometimes take for granted you can look at is the skin turgor. You can do this on the hands. And we can assess and visualize the mucous membranes and see if they're getting extremely dried out versus obviously being moist in a well-hydrated patient. We can monitor for skin integrity. This doesn't have to be hands-on or eyes-on necessarily if the patient is able to communicate and to help with the assessment. We want to assess for any type of redness or excoriation, especially if this is a bout that has gone on for several days. There can be a lot of inflamed skin around the perineum. So we can provide different interventions if the patient is having compromised or painful skin. For diet, we can encourage clear liquids. Think your broths, your gelatins, popsicles, while avoiding caffeine. Again, diarrhea is a hyperactive GI system. We wouldn't want to put caffeine in there and turn it up a notch. We want to encourage sipping of liquids regularly. And we want to encourage what they call the brat diet, which is bananas, rice, applesauce, and toast. Foods we would want to avoid would probably be highly spiced or seasoned foods that could upset the GI tract further, foods that are high in fat, and excessively large quantities of raw foods and vegetables. Anti-diarrheal medications. These are used in chronic diarrhea if it's been lasting more than a month to slow down that peristalsis. That GI tract is just hyperacute. We really need to dial it back. And there's several medications over the counter that patients will take during short-term bouts. The popular ones include Imodium and Pepto-Bismol. And again, we want to really, really limit what we're putting in our foods during these periods because we don't want to acutely impact that diarrhea episode. So some nursing interventions for constipation. We are really going to tone in and focus on positioning. We want to have seated or squatting position, or you might utilize the semi-Valor's position when on bed rest. We may look at medication intervention if this constipation has been occurring for quite a while. Think bulking. Bulking agents, a popular one over the counter is Metamucil. We may have laxatives introduced, and these are utilized to produce a more soft liquid stool. And required suppository usage may occur, which would require nursing intervention and education if the patient is going to go home on any type of suppository PRN. Suppositories are often more effective because of the rectal mucosa stimulation that occurs with administration. Again, provide privacy. This is something that you'll need to come up with your patient. And we're going to encourage those high fiber foods and get that fluid intake up. And much like we talked about, we really want to increase activity and exercise to get that peristalsis moving. If constipation continues to occur, enemas and disimpaction may be required by the medical team, including the nurse. So when we focus in on enemas and their use, really there's two groups that you would kind of want to think of. You have the cleansing and the retention. So cleansing enema can be anywhere from a small amount, think like 120 mLs, all the way to 1,000 mLs, so like an IV bag. And these are utilized for treatment of severe constipation or impaction. And you might utilize these for like a bowel prep pre-colonoscopy, or you may utilize these to empty the colon completely before providing bowel training for a patient that has chronic GI issues. And it may be used to clean and prep the colon area before some type of surgical intervention. Now, retention is usually some type of intervention that requires the enema to remain in the GI tract or the colon for a period of time for various reasons. So these are going to be smaller volume because, again, the expectation is that this stays within the patient for a period of time, usually 90 to maybe 140 mLs of solution. So you may have an oil retention that can be used to soften the stool and lubricate the rectum as a oil retention to disimpaction. To define disimpaction, disimpaction is a medical intervention that's going to break up a hardened mass in the colon into pieces and extract those pieces out in smaller bits so that the colon can be freed of the mass. An oil retention, may be used for disimpaction versus an actual manual disimpaction, which would be removing small pieces manually. We might have a medicated retention enema, so they may have antibiotics or some type of parasitic or intestinal worm medication that we're getting rid of a parasite. We're providing intervention because the patient has some type of parasite in the colon. Again, disimpaction can be done with the use of enemas, so these are not mutually exclusive definitions, or disimpaction can occur manually removing that hardened mass and moving it piece by piece so that we can try to bowel train and get that GI tract operating normally again. Let's talk about bowel incontinence. So Bowel incontinence, we can have different either external or internal interventions paired with bowel training while we try to get this GI issue figured out for the patient. We can utilize these for chronic constipation, impaction, or bowel incontinence. External fecal collection system, or often referred to as incontinence pouches, can be used to protect the perineal skin and collect large fecal samples. These pouch systems are similar to what is used for patients with ostomies. We may be required to use indwelling fecal drainage devices. These are commonly utilized in bed bounds or completely immobilized ill patients. They consist of soft, latex-free catheters and collection bag systems. The tubing system is inserted into the rectum and a small balloon is filled with saline or water, much like a urinary catheter with balloon does, so that once in position, it allows the drainage system to remain in place during patient movement. When we hone in and talk about bowel training programs, we specifically want to make sure the plan is programmed and designed with the patient. We're going to increase their fiber in the diet gradually and encourage that slowly over a period of time. We want to increase fluid intake to at or more than 8 glasses of water per day. And we want to establish times for defecation, bowel training. We want to get them on a schedule. These patients probably need scheduled times so that we can regularly attempt to get that bowel regimen established. And these treatments may include stool softeners if the added fiber in the dietary tract does not work by itself. When we talk about our nursing care and bowel diversion, so we have different things that we need to monitor as the registered nurse. We want to assess the stoma. The stoma is the area or opening, much like what you see on your screen here. It should be a deep pink to brick red. It should appear visually shiny and moist. And we don't want to see like a pallor or a dusky blue, because now we're kind of honing in and thinking ischemia. If we see brown or even black areas, there's already necrosis or death of tissue occurring. And lastly, we just want to highlight that educating our patients with newly placed stomas, we can encourage them and let them know that after around 6 to 8 weeks, they'll notice the stoma will permanently retain a regular size. And both the nurse and patient should understand to expect a protrusion of the stoma somewhere from a half to 1 inch above the abdomen skin. We also want to monitor the amount and type of effluent that is leaving the ostomy. Depending on where and what the patient is eating, this can change. And what will happen is some of those more liquidy based stools could have more enzymes in them from breaking down the food in various parts of the GI tract. So we really want to monitor the skin and stoma around that surrounding area for breakdown. Our patients are going to need time to adjust to having an ostomy. They also have a learning curve on how to apply stoma appliance with pouch. They may need to adjust their diet and avoid oddball things that most people don't have to think about. We have to encourage our patients to avoid chewing gum, food that causes weird odors or gas may include beer, sodas, dairy, especially if they're already having mild symptoms of lactose intolerance. Other highly flatulent foods such as eggs, melons, asparagus, and broccoli are all things that we want to educate our patients on. We want to chew the foods well to prevent any type of blockage or buildup in the stoma area. And the last thing I want to talk with you about today is just primary prevention and what we can teach our patients about in regards to some of these GI things that we discussed during today's lecture. So what do you need to teach people in order to identify bowel issues early? A lot of interventions that we can encourage our patients are all primary preventions. Think encouraging our patients over 50 to have a fecal blood test occurred to catch any potential chronic GI bleed or any other bleeding issues that may be occurring. We can encourage a colonoscopy, or potentially on what that patient has going on, they might actually recommend a sigmoidoscopy beginning at 45 or potentially earlier if there is a family history of any type of chronic GI issues or cancer. Most primary care providers will say at least by 50, you're going to start having colonoscopy every 5 to 10 years. And the last thing and most important thing we can educate and really teach our patients about is the importance of the dietary and regular exercise. And this lecture can provide you a lot of teaching points for your particular patient population. Thank you. I hope you got something from today's lecture, and I will see you next module.